بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, good afternoon, ladies and gentlemen. I would like to start by thanking the organizing committee for inviting me to share my humble experience in the topic of cancer-associated thrombosis. It's abbreviated by CAT, but it's not like CAT. It is very challenging clinical scenario that oncologists, hematologists, or thrombologists face on daily clinical practice. So I will start by highlighting my objectives. I will highlight the burden of cancer-associated thrombosis through prevalence of VT in this high-risk population and discuss current guidelines, recommendations, putting available low molecular heparin evidence into perspective, and discuss the data from phase 3 trials, real-world evidence, and last evolution in the treatment of cancer-associated thrombosis with NUAC or DUAC, because this is the most rapidly evolving field in the thrombosis, cancer-associated thrombosis. So to highlight you the burden and the magnitude of the disease, I will start by sharing one of patient in our thrombosis clinic. So a 31-year-old male, medically free, or not known to have any previous medical problem, presented with multiple unprovoked DVTs and BE while on anticoagulation. He presented with neck pain, swelling, and bilateral neck lumps. So on examination, he was having neck swelling with multiple bilateral cervical lymphadenopathy and the clinical evidence of left upper and lower limb DVT. So this is the patient. In the patient, you have suspicion for upper extremity DVT. You should expose the chest of the patient to look for dilated veins. It can give you a closed superficial vein, or so SVC, supravena cava thrombosis. So this patient was, treated by initial presentation, treated with low molecular heparin overlapped with vitamin K antagonist. Then the patient developed recurrence. We thought due to inadequate anticoagulation, subtherapeutic INR. Patient was switched to NUAC or DUAC. He was treated with rivaroxaban. This is the drug that is available at our center, and given he was started as acute DVT initiation, 15 milligram BID, and in the acute phase, because this is we hit hard with DVT, he developed a recurrence. So recurrence was right upper limb, then left upper limb. Then the patient, we thought that this is maybe, we suspected cancer, because if you have being upper limb DVT unprovoked, because most of upper limb DVT happens in the setting of provocation, usually mechanical factor, catheter, whether it is peripheral or a PIC line, central line, or patient who are bodybuilders who have a huge muscle bulk, called thoracic outlet syndrome. We call it Budget-Schroeder syndrome or effort-related thrombosis. But this is if you have a patient upper extremity vein thrombosis young without provocation, always think about malignancy. And in the literature, about 30% of unprovoked idiopathic upper limb DVT. So this patient shifted to low molecular heparin. Then the patient, during hospitalization, having another recurrence. So we admitted him for workup and search for malignancy. The patient developed recurrence in therapeutic eclixane. We measured anti-10A level. The anti-10A level was about 0.9, because it was 0.5 to 1. So this is the therapeutic range. In spite of that, the patient having recurrence. So we increased the dose to keep it in the supratherapeutic between 1 to 1.5. We control the patient. This is such kind of patient, we call it, you have catastrophic thrombotic syndrome. One of them, cancer, in addition to catastrophic antiphospholipid syndrome. Other cases like hemolytic uremic syndrome or etc. So these patients, usually some subset of patients, they develop thrombosis whatever anticoagulant therapy. So this is the confirmation of upper limb DVT by ultrasound. It was left subclavian, axillary vein. It was as well in the basilic and brachial vein and cephalic vein. So all veins occluded. In addition, you have to do CT for that. We did CT that found supravena cava thrombosis and bilateral pulmonary nodule. Search for malignancy workup showed adenocarcinoma of the hepatobiliary tract, metastatic everywhere. Young patient. He's just, I mentioned, okay, he's in 27 or 31. So just this is, I think, a good introduction to the burden of the disease. Unprovoked VTE may be the earliest sign of cancer, and up to 10% of with unprovoked VTE receive a diagnosis of cancer in the year after their diagnosis of VTE, and the highest incidence the first 6 months. And after, the incidence rate of cancer diagnosis gradually declines and returns to the rate in the general population after 1 year. So the first 1 year is the highest risk. If you want patient, usually if they have the earliest presentation is unprovoked VTE, they might present with cancer. After 1 year, they are comparable to general population. It's about common, about if you have 100 patients with venous thrombosis, about 20% attributed to malignancy, and about 10% in all, as I mentioned, idiopathic VTE, and there is increased risk of recurrence and can occur with adequate INR. We call it warfarin failure. One of the causes, if you have warfarin failure, either it is cancer, Behçet disease, antiphospholipid syndrome, this patient, or heparin-induced thrombocytopenia. So such patient, they can have breakthrough thrombosis on adequate anticoagulation. And there is increased risk of bleeding during anticoagulation, challenging because of the chemotherapy, because of the thrombocytopenia, comorbidity, they can have bleeding on anticoagulant therapy. So interestingly, this syndrome was discovered, as you see, this is the picture of Trousseau. He is a French clinician, scientist. He is the one who mentioned that venous thrombosis of the upper and lower extremity associated with visceral cancer. And Trousseau diagnosed himself with this condition. Trousseau in 1861 stated that if the diagnosis of a suspected carcinoma of an internal organ should not be verified, then the sudden and appearance of unprovoked or spontaneous thrombophlebitis in larger vein, usually it's approved for diagnosis of internal malignancy. So he is the first one. I'm sure if you have left supraclavicular lymph node, we say this is Virchow's lymph node. And again, we say this is Trousseau syndrome. So he's the first one who pointed out that this condition. VT is one of the leading causes of mortality in patients with malignancy, and cancer increase the risk of several fold, in particular among inpatient and those receiving active therapy. So in this instance of VTE, as I mentioned, about 20% of all patients with venous thrombosis secondary to cancer. So there are risk factor cancer-related and treatment-related or patient-related or biomarkers you have. So primary site of malignancy is very important, like adenocarcinoma, they secrete mucin, increase risk more than squamous cell carcinoma. Stage, advanced stage, metastatic is higher risk, as I mentioned already, histopathology. And the primary site of malignancy, because they found pancreatic, is the highest one, followed by prostate, lung, breast. Certain cancers having higher risk than others, and time since diagnosis, risk increasing during the first 3 to 6 months. This is the highest period, and up to 1 year. Chemotherapy, if you have anti-angiogenesis agent, hormonal therapy, radiation therapy, and surgery, more than 60-minute blood transfusion, and indwelling valence catheter. So patient comorbidity is very important, like increased age, ethnicity, comorbidity, and very important, obesity and performance status. The biomarkers, it was found in some studies, that's why used in the corona score. So platelet count more than 350 increase the risk of cancer cell thrombosis, and leukocytosis more than 11,000, and anemia. Prophylaxis due to increased risk. For treatment of patient, so if you have cancer-associated thrombosis, so low-mercury heparin is preferred over unfractionated heparin for initiation, 5 to 10 days of anticoagulation with a newly diagnosed VTE who don't have severe renal impairment less than 30. And for the maintenance, low-mercury heparin for at least 6 months. So all studies, CLOT, CATCH trial, LIGHT trial, should be used for up to 6 months due to improved efficacy over vitamin K antagonists, and I will discuss some studies. So vitamin K antagonists are an acceptable alternative for long-term therapy if lumoxitibarine is not available as second choice. So ACCP guideline, ASCO, all they recommend lumoxitibarine as the first-line therapy. So anticoagulation with lumoxitibarine or vitamin K antagonist beyond initial 6 months may be considered for select patient with active. If they say this is cancer, one of the transient reversible risk factor. If it is cured, so up to 6 months you stop. If it is uncured, metastatic, so it should be continued beyond 6 months. And the insertion of vena cava filter is only indicated for patient with contraindication to anticoagulation therapy. It may be considered as an adjuvant to anticoagulation in patient with progression of thrombosis if you have breakthrough thrombosis. Very important, we are nowadays leaning, or shying away from IVC filter insertion. It has to be inserted in the right clinical setting. Because it's been abused, especially by vascular surgeon, private hospital. Any patient with acute DVT, they will insert IVC filter. Remember, this is a double procedure. Insertion, this is one procedure, and retrieval, another procedure. And if you don't retrieve within the, let's say, 6 weeks, some up to 3 months, then it will be permanent IVC filter. And if you stop anticoagulation, there will be increased risk of recurrence, recurrent DVT. So very careful about it. So method for treatment of patient with cancer, for patient with primary CNS malignancy, you have to be, cautious about intracranial hemorrhage. You have to, take, into account if you start anticoagulation, you repeat CT to make sure there will be no hemorrhagic transformation. So careful monitoring is necessary to limit the risk of hemorrhagic transformation. What's the best method for treatment of patient with cancer with established VTE to prevent recurrence? Based on consensus, incidental BE and DVT should be treated, because other diseases, if you have incidental PE, which is a common, or DVT, especially BE, subsegmental BE, we don't usually lean to treatment. But if in cancer, all the guidelines recommend to treat patient as it is symptomatic. So incidental asymptomatic PE in cancer, I already mentioned. So very important to keep in mind any goals of care in cancer thrombosis, the VTE symptoms, symptomatic or not, tolerability, adherence, cancer status and treatment, VTE recurrent risk, major bleeding, and preference. Very important, you have to keep the patient in the decision-making process, because all guidelines, they recommend that a patient preference and values count. If the patient is not willing to take injectable drug or cannot afford, so you have to negotiate other option with the patient. This is for screening malignancy, because I brought that case. It is very controversial, but available data don't support an extensive search for occult malignancy. But very important, you have to pursue symptoms or signs which suggest an underlying malignancy, and to ensure that age-appropriate screening tests have been performed. If the patient like that more than 50, I will do colonoscopy, because if a patient 40, I will do mammography. So we do age and cancer appropriate gender screening rather than just random shooting, doing all malignancy workup in patient with unprovoked VTE. So this is very important, you have to keep in mind. This is the paper published 2015. This is, they ask CT abdomen for CT abdomen pelvis for unprovoked VTE. They don't recommend, because this study did not show any additional value. Again, to draw your attention for prophylaxis and treatment of VTE in patient with cancer, the Saudi Clinical Practice Guideline. This is collaborative effort between Ministry of Health and McMaster and Dr. Khalid Saleh, Dr. Tariq, okay, and myself. We are, part of this expert panel. And the risk, very interesting, the risk of VTE, that in the diagnosis, and it can increase during hospitalization, so during remission, decrease, and sometimes recurrence of VTE indicate for you there is relapse of the disease and metastasis. So this is very important. You have to keep in mind that what we call VTE risk varies over the natural history of cancer, and identifying patient at risk of chemotherapy associated thrombosis. This is for ambulatory patient. This is already I mentioned. So it depends on high risk lung, lymphoma, gynecologic, genitourinary, excluding prostate, platelet count, hemoglobin, leukocyte count, and obesity. And very important, if you stop anticoagulation for patients who have cancer, the risk of recurrence is very high. So 20% compared to patients who have no malignancy, and that the benefit is outweighing the risk of bleeding or clinically relevant bleeding. And these are the clinical trials that used, they compare vitamin K antagonist to lumefantrine, one of them the famous CLOT trial. They compared dalteparin with vitamin K antagonist, and CATCH trial they compared tinzaparin with vitamin K antagonist. Be careful about the CLOT trial, because my training in McMaster University, we are using this one, that the first month it's the highest risk of thrombosis recurrence. So they hit hard, they use full dose, about 200 units per kg. Then after 1 month, they reduce it to 150. That's why any patient with cancer-related thrombosis, first month you give full dose, then you decrease. Let's say for enoxaparin, if you have it only, you give 1 milligram per kg BID the first month. After that, you give 150 milligram per kg. This is a reduced dose compared to that one. So all these, this is a CLOT trial that's showing that about 50% reduction in the recurrence rate and bleeding rate. It was just, if you see, this is the bar for dalteparin, so even less than bleeding due to warfarin. So these are the NOACs trials. Remember, this is subgroup analysis, because all we have Einstein DVT BE for rivaroxaban compared to warfarin. You have Einstein extension amplify for rivaroxaban, and this is amplify extension recover remedy. Without just going over details, all they showed that rivaroxaban or dabigatran or apixaban or edoxaban not inferior to warfarin. Remember, this is subgroup analysis. The study was not powered to compare warfarin with new oral anticoagulants. So then we have this is recently published about 2 months back, Hokusai VTE cancer, and this is compared warfarin with edoxaban, and they found this study in addition to another study, we call it Select D. They compared rivaroxaban with warfarin. All they showed, this is very interesting, you can see the result. The recurrent VTE 3.4% in favor of edoxaban, so the recurrence rate is less, but the bleeding rate, major bleeding, 2.9 in favor of dalteparin. So it was more effective in the prevention of VTE recurrence, but causing more bleeding. That's why the composite, the primary endpoint was a composite between recurrence and major bleeding, and they say this is edoxaban non-inferior to warfarin. This is the first study that give you, remember, but there are some caveat to discuss about the study. Again, the same goes for Select D. They found the recurrence rate is in favor of rivaroxaban, so it is more potent and prevention of recurrence, but causing more major bleeding. So these drugs, they found that very important in patient with, especially with this, the Hokusai VTE cancer, high bleeding. The bleeding rate was more in GI malignancy, esophageal, gastric malignancy, colon malignancy. So more bleeding in GI malignancy and genitourinary cancer, particularly patient with urological malignancy. So when you use composite point, it's difficult to convince patient. Tell patient, oh, this is drug causing less recurrence, but causing more bleeding. So that's why we put, goals of care, put the patient in the clinical perspective. So we have risk of recurrence, we have risk of major bleeding, then we have the patient preference and values. We have to keep it in mind. Cost wise, here the patient is paid, is not paying. So, but this is very important. If the patient paying the cost, you have to keep it in mind. So, sure, I'm finishing on time. So, summary and take-home messages. Treatment in 2018, that patient lumefantrine is a standard of care, but there are group of patients, because the studies we have Hokusai VTE and Select D, and there is Carabago. This is for apixaban compared to warfarin. This is ongoing trial. So giving you, I will say, green light that DUAC or NOAC can be used in such a patient, but you have to select your patient, or we call it individualized approach. So individualized approach based on risk of bleeding versus recurrence, and incorporating patient preferences. For cancer patient with a new VTE, low risk of bleeding and no drug-drug interaction, with current systemic therapy, treat with NOACs. Be careful about this, okay? So you select your patient. because we have evidence-based. Before, we don't have evidence. Subgroup analysis is not direct evidence. So now we have direct evidence. And for cancer patient with a new VTE and high risk of bleeding, treat with lumateperone. And high risk bleeding, important patient with luminal GI cancer with an intact primary cancer at risk of bleeding from genitourinary tract, especially bladder. We found these patients really challenging clinical practice. I don't treat them with, because remember, all DUAC, they have increased the risk of genitourinary bleeding. In addition, you put for them, if you have bladder or nephrostomy tube, definitely they will bleed. So I'm not using these drugs. Or patient with active GI mucosal abnormalities such as duodenal ulcer, gastritis, or esophagitis, or colitis, I will not use NUAC. I will use lumateperone. So I hope my presentation was not boring. Okay, thank you very much. Okay.
So thank you. Now, since we have about 5 minutes, we can take question for Dr. Mohammed and Dr. Aiz's presentation. So if anyone have a question for either of the speakers. Tafadhal.
Excellent question. So there are studies, because the review of the topic, there are the study or all the previous studies I showed up to 6 months. But there are other studies, 2 studies I did not include, they use it beyond 6 months. So beyond 6 months for patients who have indication like uncured malignancy, so they continued and they found the benefit is outweighing the risk, the prevention of recurrence. But I did not include those studies. So the guideline up to 6 months, and they're saying, okay, if you have cured malignancy, you treat up to 6 months. If it is uncured, we call it persistent risk factor, it will be continued. And let's say there is no evidence behind it, okay? But the sense or common sense saying this is as long as the risk factor is there, since this is provoked by strong risk factor for VT, I will continue, and would like maybe to hear maybe from my colleagues because they deal more with cancer thrombosis. Dr. Khalid.
So actually we do treat, so beyond cure, we treat for about 3 to 6 months. As long as you have an active cancer on chemotherapy, they will carry. Now the biggest problem we face when you have a lady who's like cured but she's taking tamoxifen and she had a cancer-related thrombosis. So tamoxifen can cause us kind of an OCP. Right now slightly better with the presence of NOACs, but it's an area which is not very well studied.